When Medicare Advantage came out, they made clear that their goal was value-based healthcare, which is a nice nomenclature to say you have to do preventive healthcare. We'll say your doctor and your insurance company need you to come in for this visit. The exact verbiage depends upon what the practice wants us to say. Some practices want us to say insurance company, some want us to say doctor's name. And we'll set up an appointment for them, say for the annual wellness visit, Medicare Advantage, right? And we'll make sure we have it set up back to back where the nurses do 40 minutes and the doctor does 20 minutes. But we are measured on our success in doing that, both more effectively than humans do with our AI agents and more cost effectively. So that's the first thing we do. There's another part of value-based healthcare, which is referral from primary care to specialists. One, believe it or not, is that we have to find the specialist. In rural areas, that's hard. Two is once we find the specialist, we have to make sure the patients show up for the appointments. It's not easy. Three, we want to get the results back from the specialist to primary care. And four, we need to make it as cost effective as possible. And of course, the population as well, rural America, is aging actually more rapidly than the metropolitan area. So we're getting more Medicare Advantage and Medicare patients. A lot of Medicaid, and this is the population we know best how to deal with because of our FQHC work. Technology-wise, what we've honed, which we can use with Oracle but not with Epic, is our ability to do RPA. So in the FQHC space, we see a lot of next-gen, which is API-driven. We see a lot of eClinical works, which we can use RPA on. We can use RPA on Oracle Cerner, right? We can't use it on Epic. Right. Say we get somebody in for their diabetic checkup, but we want to make note in the note that, hey, this person is also due for renewal of their insurance coverage. We will do that, right? Most of the other folks cannot go in and manipulate the clinical notes. We can do that. So the thing is, they have the same problem. They have a huge Medicaid population. And how do you turn that around? Well, NYU gave them more money, but it doesn't change the population you're dealing with, right? That population has the same issues. It's hard to reach them. It's hard to get them to come in. They'll come in when things are acute. So this is where our FQHC experience actually makes us uniquely qualified to help with certain communities.